Welcome to Chapter 7, Learners with Attention Deficit Disorder. And as you look at this PowerPoint, or this chapter, I'd like you to notice that there are, although it's one title, there are really two different types of disorder within the title. So learners with attention deficit is one type of disorder, and hyperactivity is another. So I'd like you to pay attention to that idea of ADHD being two disorders. If you look at the second slide, the story of Fidgety Philip, the point of that slide is to share with you that as far back as the late 1700s, there's evidence in the literature of doctors referring to symptoms associated with ADHD in certain children. And as you read those poems, I'd like you to ask the question is, what stands out to you regarding symptoms? So as you read the poems and you hear them, what catches your attention relative to the disorder or the symptoms? What do you hear that triggers the idea that a student may have ADHD? What's it like to have ADHD? In our PowerPoints, we try to give you clips that kind of give you an idea of what it's like to be inside, what it's like to have a particular disorder, although we really can never know what it's like unless we have the disorder. But this clip might help you with distinguishing some general features of ADHD. As we've come to learn more about ADHD, our attitude and our understanding and a treatment for this disability has changed over the years. And one aspect is that of ADHD is that its impact can have in some individuals that it can extend beyond childhood and into adulthood. And how might ADHD hinder an adult? Again, in this class, we're mostly looking at how does it impact children, but when you're looking at ADHD, how might it impact adults as well? In our next slide, Dr. Adam Weichard and Sir Alexander Crichton. Weichard was a highly respected German physician who wrote a textbook published in the late 1700s, 1773 to 1775. And this is just, although he's German, just to give you kind of a point of reference, this is just prior to the American Revolution, so it gives you an idea of what timeline or what time frame this occurred. Anyhow, Weichard devotes a whole chapter on the idea of inattention, and a quote from his textbook says, every humming fly, every shadow, every sound are memories of an old stories drawing him off task to other imaginations, hearing only half of everything. So we find that even in the 1700s, they really can kind of notice and articulate this idea of inattention. He is credited as being this, Weichard, Dr. Adam Weichard, as being the first to address the issue of inattention in scientific literature. And as you see on the slide, it's the cover of his book on the left. Now, Alexander Crichton is a Scottish physician who wrote the need for individuals to put forth effort to attend to a task. And this was in 1798, which would have been after the American Revolution. Attention was not automatic, and that some individuals could be born with attention disorders. So again, the point on these two slides is to let you know that inattention has been a topic around for hundreds of years that has been first noticed by physicians. This next gentleman, and again we're trying to establish a historical context here for you, is Dr. George Still. So in 1902, the beginning of the 1900s, George Still delivered 3 lectures in which he described children who displayed a spitefulness, a cruelty, disobedience, and impulsivity, and problems with attention and hyperactivity. He noted that these children had ineffective, quote-unquote, moral control. And so my question is there a connection between moral behavior and ADHD? Over the years, Still's contention that behavior of the children he studied is due to a lack of moral control is probably inaccurate in many cases. However, the cases he studied had similarities in the behaviors that we study today, known as ADHD. So if you see the bottom of pages 152, 153 in your text for these similarities, and click on the link and you can read more about this ADHD pioneer. So as far back as the late 1700s, up through the 1800s, up through the early part of the 1900s, the 20th century, we see this thread of physicians who are beginning to pay attention to students who have trouble controlling their behavior. So to summarize, we take a look at the next slide, slide 7. You have George Still, who talked about the idea of defective moral control in children. He labeled or provided some descriptors of those students, and we are able to see many of the similarities in ADHD, students with ADHD today, in the work of these early pioneers. Now, George Still's cases on slide 8 are similar to today's population. Many of the children have normal intelligences or intelligence. There's mild brain pathology in these conditions. The condition of ADHD is more prevalent in males than females. It can be hereditary based, and relatives also had physical or psychological problems such as depression and tics that were associated with this disorder. So if we move on in the 1920s, now World War I is usually, I believe it's 1913, 1914 till about 1918. So out of that war, we have some studies of individuals and inattentive or hyperactive behavior. So if you see the Kurt Goldstein on the left, he studied World War I soldiers, especially those who were brain injured. We can see the soldier on the right-hand side. And soon after Still's lecture, Goldstein came on the scene and did research with World War I soldiers, and he found in soldiers who had head injuries from the war a form of repeated behaviors known as perseveration. Perseveration. It's hard for me to say that. All right, and perseveration is the mimicking or the repeating of certain behaviors. Is a characteristic today of some children who have ADHD. So, for example, tapping pencils, might be certain behavior in terms of washing hands. It might be something associated or behaviors associated with tics or saying a word over and over and over again. He found that soldiers that had these types of injuries to the brain tended to have this condition called perseveration. So we have a review slide there regarding Goldstein's brain-injured soldiers, and a little descriptor of perseveration, and a film clip there that you might be interested in watching. We also have another person, last name is Strauss, and in the 30s and 40s, Alfred Strauss, who escaped Nazi Germany, came to the United States and conducted research on behaviors of distractibility and hyperactivity, and he found that those with mental retardation, those are intellectual disabilities, those would be the chapter that we studied in Chapter 5, was the same as those behaviors researched by Goldstein in World War I. In other words, he found the same types of behaviors in World War I soldiers as we found in those with disabilities. And he discovered that children with brain damage tended to see the background of figures as opposed to the foreground. So if you look at the summaries in the next two slides, the link will illustrate what perseveration is and how to deal with it in working with young children. So this link, I think, would be of interest to you. So Alfred Strauss, Heinz Werner was another person who worked in this area, but again, Strauss's hypothesis, called the Strauss syndrome, was that those with brain damage were more likely to see the background rather than the foreground of a figure. All right, there's an example. Do you see the two faces in the foreground, or do you see the face in the background? Strauss noted that those with brain damage were more likely to be confused by this figure-ground relationship, and would most likely see the background as opposed to the foreground. In other words, they'd be more likely to see the face than the face. And do you see a young lady here? Background? Or do you see an old lady in the foreground? William Cruikshank in the 1950s, in his research around the mid-century, probably close to 60 years ago, focused on distractibility and hyperactivity and connected those conditions to those with brain damage or intellectual deficiencies. So William Cruikshank revealed that those with normal intelligence could also display those conditions. So Cruikshank's research opened the door to begin to look at certain behaviors with those with normal intelligence. So in the past, we saw that inattention was related back to those who had abnormal behavior. Cruikshank's work said that yes, you can have abnormal intelligence. Cruikshank's work said that people with normal intelligence can have defining characteristics of ADHD. So there's a summary slide, slide 15, of Cruikshank's work. And he was the first to establish educational programs that met ADHD criteria. So we go back to the 1700s, late 1700s, where they began to discover or talk about or identify those with inattentive behavior, up through the early 1900s when the research was done on World War I soldiers, and then began to look at those with abnormal intelligence. And now in the mid-50s, 1950s, we begin to see that ADHD is related to those with normal intelligence as well. So slide 16 asks you this question: what are some conclusions that you can draw from this brief history of emotional and behavior disorders? And can you share at least one contribution made by the following: Weikart, Crichton, Still, Goldstein, Werner, and Strauss, and Cruikshank. So I think becoming familiar with the contributions that these individuals made will provide you a historical context in which to see ADHD. So slide 17 gives you some implications for the early pioneers, some findings, key findings that are connected or associated with the work of these individuals, these researchers. And note most of them were physicians. And slide 18 again is another review or another way to look at the contributions that these individuals made. So when we go to slide 19, 20, 21, 22, 23, 24, you'll notice that those are self-check slides and along with the answer. So this would be a good way to kind of check yourself. Slide 25. When beyond the history of ADHD or beyond the history of any disorder, it's important to take a look at the label. And whenever, hopefully you've picked up by now, the fact that when you're working in the area of disabilities, labels become a very big part. The language becomes a very big part of communicating information about the disability. So you can see that the change over time of ADHD in the label. In 1950s, it was referred to, someone had type of behaviors associated with ADHD, they would call them minimal brain injury. In other words, they thought that there was something physically wrong with the brain. When we get into the 1960s, ADHD was referred to as hyperactive child syndrome. So someone who had what we call today ADHD, we call that child hyperactive, and that's still a term that's actively used today. And then when we get into the 1980s, we have ADD, attention deficit disorder, and now we realize that really there are two conditions that relate, and that's attention deficit hyperactivity disorder, that there are really two disorders associated there. And most authorities do not view hyperactivity as the primary deficit in ADHD. The inattention has recently received much more focus. But the point here is, notice that the definitions over the years have changed, and probably will change again. So when we take a look at ADHD, we can put those behaviors into three categories. And note the three characteristics were not always included in earlier definitions. So we have ADHD, predominantly inattentive type, associated with inattention. And just look to the right there, you'll see the inattentive student. We have ADHD, predominantly hyperactive or impulsive type. This is the active movement. This is the hyperactivity aspect of it. And then you have a condition where you have both types that are combined. The student may be inattentive and they may be hyperactive. Now let's find out more about ADHD and the behaviors associated with the disability. If you click on the link, when looking at the two pictures above, what distinguishes the no ADHD from the ADHD? So as you look at the two pictures and compare and contrast them, what do you see as similarities and what do you see as differences? And then click on the link to find out a little bit more about the role the brain plays in the conditions of ADHD. All right. This is Katie Couric, and she also has some interesting information, a very short clip, about 8 minutes, about ADHD, but I think you'll enjoy the clip. Being able to hear personal experiences of people that have ADHD or talk about people they've known that had ADHD helps to better understand the disorder and helps to provide a context when we're studying ADHD. So, as we've done in the last chapters, once we try to understand the history, once we try to define it and talk about labels, then we also take a look at the prevalence. And so this slide 29, has some details, some facts about prevalence. It's the most frequent reason for behavior referrals in schools. ADHD affects 3 to 7% of the school population. It's a very difficult disability to try to get an exact percent for in a school, but so it's better to communicate the prevalence in terms of a range. There's no separate category for ADHD. So when you look at the federal definition of disabilities, ADHD is listed as other health impaired. That was a category that was recently added. 3-to-1 ratio for boys. And question is, as we look at ADHD, again, there's 3 different types: hyperactive, inattentive, then a combined. There's theories that boys are more hyperactive and girls are less attentive. Something to be thinking about. Is it a U.S. phenomena? If so, why does it occur in other countries? So the prevalence raises some questions, and there's a link here to hear about the external factors, which we call the 3 S's, that I think you'll find interesting as well. If we go to slide 30, how many students with ADHD are served with special ed? Well, around 1975, I began teaching in 1974, and at that time we never really heard of ADHD. We would refer to someone as being hyper, but it wasn't really connected to a disability. And so there wasn't really what we would call an advocacy base. There wasn't the parents of children with ADHD, since it wasn't classified. There was very little parent advocacy, very little advocacy within the field itself, because again, it wasn't really classified at that time. And in 1990, with the reauthorization of IDEA, children and adults with ADD came into being, and people began to advocate for making ADHD a special education category, just like learning disabilities, just like intellectual disabilities. But this did not happen. And so in 1991, the DOE, Department of Education, stated students with ADHD could fall under what they call an other health impaired category. That's a cluster of other disabilities. Identification. Today, nowadays, someone who has ADHD, it's not something that you can really diagnose within the school. It requires a medical examination. It requires a clinical interview. which can be done in schools with a school psychologist. Usually involves teacher and parent rating scales where they rate certain behaviors of the individual student, and observations, usually by a school psychologist or a behavior specialist, are also conducted. So the key here is that there are many people that are involved in identifying and classifying someone who has ADHD. So if we go to slide 32, the medical exam is, do we want to rule out something medically? Could it be a brain tumor? Could there be a thyroid problem? Could there be a seizure? Could there be something physically wrong with the student? The clinical interview takes a look at the physical, psychological, as well as the family dynamics, interactions with peers. Could there be something in the parenting of a student that might be causing this? I guess my question here is, why would it be important to have both a medical exam and a clinical interview? What value would that be? And then the point here is that children with ADHD may look normal in a doctor's office, but may act differently when they are in the classroom. Grading scales given to parents, teachers, in some cases a child. Why would that be important? Why would you want to have input or perspective from parents? And when you're looking at rating scales, those are usually done on a Likert scale or on a numerical basis. So you're able to, what we would call, quantify results of scales. Usually have ranges, and usually the numbers are translated into something that's meaningful for the school psychologist or the person who's interpreting the results. Now, the observations may have a special room where a child can be observed in tasks requiring sustained attention, or it might be just in the regular classroom. So all of those methods are important: the medical, the clinical interview, the rating scales, and the observations, before determining whether or not someone might have ADHD or fall into that category. So if we look at slides 34, slides 35, slides 36, 37, 38, you'll see that those are review slides. Now we go to slide 39, and we talk, again, as we follow the normal progression of the chapter, we talk about the causes. And in the early part of the 20th century, as we've spoken earlier, ADHD was classified as minimally brain damaged. In other words, there was something physically wrong with the brain. We know now through MRIs and PET scans that really there's a neurological dysfunction of the brain. And here's a clip that I believe that you'll enjoy watching. It's a 2-minute video to gain a sense in terms of what causes ADHD. Now on slide 40, causes of ADHD. Basically what it comes down to is that there's connections in the brain that are poor or inadequate, or those connections aren't working well. They involve chemicals, dopamine and norepinephrine, chemicals in the brain that help send messages between neurons. Individuals with ADHD may not have enough of those chemicals, and that might be the cause of either inattention or hyperactivity. It also can be hereditary, and also toxins and medical factors, alcohol and tobacco use can also be a cause of those. The areas of the brain on slide 41 are affected are the prefrontal lobes, the basal ganglia, cerebellum, and corpus callosum. Those are areas of the brain that are affected. or relate to ADHD. Notice that the prefrontal lobes is where the executive functions take place, really the ability to regulate one's behavior. And so my question would be, why, in what ways would the prefrontal and the frontal lobes relate to ADHD? And then in what ways would the basal ganglia, this is the motor coordination function, how would those relate to ADHD? Slide 42, you can see the different aspects or parts of the brain that are affected. And there's an informative clip that will help you better understand the relationship between the parts of the brain and ADHD. This also clip is an excellent explanation of how ADHD affects the brain. This clip is about 4 minutes. I believe the previous one is just a few minutes. I don't think it's very long. On slide 44, when we talk about factors, hereditary factors, if a child has ADHD, the chances his or her sibling having ADHD is a third, 32%. Twin studies, a second identical twin more likely to have ADHD than a fraternal twin. And genetics, the DNA, protein, genes involved in regulating dopamine, which is the chemical, again, that people with ADHD don't have enough of, can also cause issues. And again, there's a link to how, an explanation of how ADHD relates to heredity and genetics. Toxins, as we mentioned before, can also relate to or affect a person in a way that causes them to have ADHD. So lead, alcohol, drugs are possible causes for ADHD. Slide 47, 48, 49, 50, 51, 52, 53, 54 are all self-check, way to check on your understanding of the content so far. So if we go to slide 55, what are the psychological and behavior characteristics? You can see on the left-hand side the characteristics, and on the right-hand side you can see what's involved in those characteristics. So someone with ADHD would have behavioral inhibition. If you have behavioral inhibition, you are able to delay a response to a particular stimulus. You're able to interpret the response if it doesn't seem to be quite appropriate, and you're able to protect the response from competing stimuli. In other words, in terms of behavioral inhibition, you're able to see a situation or read a situation and be able to respond appropriately. Executive function permits individuals to self-regulate behavior. Time management, they're aware of what needs to be done and when. Again, people with ADHD have trouble focusing on that. And there's persistent goal behavior, its ability to achieve goals. Those with ADHD have an inability to achieve goals, and it stems from poor interference control. So there's so many stimuli in their environment that's very difficult for them to focus on one particular goal. This is just to take a humor break. This gives you an idea. Jim Carrey in the movie Liar Liar, he really has no filter, and he has very little control over what he says and how he acts. Barkley is an important individual in terms of identifying the characteristics of ADHD, so it'll be important for you to take a look at this. There's also a clip there, and again, this Barkley model goes into depth in terms of behavior inhibition. So the ability to wait one's turn, the ability to interpret a response, to protect a response from distracting stimuli. Those are things that quote unquote normal people can do. If you have ADHD, it's very difficult for those individuals to do that. Again, with executive functions, and you can go ahead and read this. Those who have ADHD have problems in this particular area. And on page 59, time awareness, persistent goal-directed behavior, and adaptive behavior. So these tend to be the psychological or behavior characteristics that really kind of define whether someone does or does not have ADHD. You would take these categories, line them up, and then most of the assessments, most of the observations, the rating scales, those kinds of things will line up with these categories. Problem socializing with peers. Also, in addition to ADHD, there may be other problems, emotional problems. There might be learning disabilities are associated with ADHD. So 25 to 50% of the people with ADHD also exhibit some form of emotional or behavior disorder. And check out this link and the social skills app known as Social Navigator. Might be helpful, beneficial to you. The marshmallow experience is, or study experiment is very interesting. If you look on pages 161 and 162 in your text, you can read about it. You can also watch this experiment on a YouTube video. It kind of gives you an idea of the difference between those who are able to delay gratification as opposed to those who aren't. The difference between those who are impulsive and those who are not, and again, might have some implications there for ADHD. So if we look at slide 62 all the way through 65, those are review study slides. And then some ways in which we assess ADHD, functional behavior assessment is one way, contingency-based self-management is another, and there's a clip there, slide, that may be helpful to you. Being able to teach people to self-monitor themselves, to be able to think about a situation and consider alternative ways of reacting is important. Contingency models involve having students track and self-monitoring, monitor their behavior. A combination of functional behavior assessment and contingency-based assessment has proved to be successful in improving behavior. And you can see page 186 for additional information. And there's a brief clip here on contingency maps. This can be a benefit to teachers when dealing with students who have misbehaviors. And this is more information on slide 68 in terms of self-monitoring and group contingency, so you can go ahead and read that. Slide 69 provides some guidance to teachers in terms of working with students to be able to set boundaries, clear boundaries and parameters. So this slide talks about those things that should be done. Slide 70 talks about some of the delivery models. Students with ADHD are across this particular spectrum. Again, it's not a separate category. Fewer than half the ADHD students receive services, and placement of ADHD students should be on an individual basis based on the medical, the rating scales, the observations, those kinds of things. So planning for ADHD students in your classroom, This gives you some ideas of some things that you can do to help better meet the needs of students with ADHD or that are hyperactive or inattentive, even if they have not been classified as having that disability. That's slide 71, 72. 73, additional classroom strategies. You might want to watch this clip and take notes. I think you'll find it very interesting. And some medical considerations. Oftentimes, in some cases, students with ADHD might be taking a particular drug, Ritalin or Adderall, to increase those dopamine levels. So teachers really kind of have to have some knowledge of how those medications work, situations in which they will work and situations when they won't work, what happens when medication wears off, what happens if a student doesn't get his medications, even procedures in terms of how a student gets that medication if they're in school is important. So the research on medication is important, and this provides a summary, a review of the research. One of the things that I encountered as a principal is that parents would say, I don't want my child on medication because it leads to further or easier access to other drugs. And as you notice here on the slide, that's not necessarily proven by research. So I would look at the slide carefully. Some cautions I think are important. Academic outcomes, if a child is placed on drugs, may not be dramatic. Dosages must be monitored. It's not a panacea. It's not necessarily a cure-all. It's a controlled substance. Others could experiment with it, and so you have to be careful with that. Communication, who knows or who should know that a particular student is on medication. Those are all important considerations. Okay. And another slide 76, on medication versus behavior management. In other words, do you have a student take drugs, or is there a way to manage that student while he or she is not on drugs? And oftentimes it could be a combination. Slide 77 is assessment of progress. How do you determine whether a student is making progress? And 78 is transition to adulthood. Page 94, I think, will be an important page to read. The rest of the slides have to do with a review. So that is all the information on ADHD. It's a lot of information to try to absorb, but I hope this was helpful to you.